All right, so let's talk about medications for the endocrine system. So we're going to be looking at first medications for diabetes, and then we're going to move on to some other endocrine disorders like thyroid, adrenal, things like that. So diabetes. The first thing we need to know is how to recognize hyperglycemia versus hypoglycemia. Hyperglycemia, we're going to have our 3 P's. Polyphagia, meaning we're always hungry. Polydipsia, meaning we're always thirsty. And polyuria, meaning that we pee a lot. For hypoglycemia, we're going to have things like tachycardia, palpitations, diaphoresis. Diaphoresis is that extensive sweating and shakiness. So the way I tell you to remember that is if they're cold and clammy and shaky, they need candy. So now we're going to talk about oral anti-diabetics. Oral anti-diabetics, these are going to be medications typically used by our type 2 diabetics. Our type 2 diabetics are ones who can make their own insulin, but they have done things to their body to make it so that they can't. So for a type 2 diabetic, insulin is not going to be our go-to choice. It's going to be diet, exercise, and then an oral medication. If later down the road that doesn't work, we will progress to insulin for a type 2, but it's not your starting point. Whereas in type 1, your body is not allowing you to create insulin. It's essentially a form of an autoimmune disorder. And so you need insulin in your body because your body produces none. So this, for type 1 diabetes, we are going to start with insulin because we have to. Looking at our sulfonylureas to start with, glipizide is your big one for that. This medication helps stimulate our pancreas to make its own insulin. So this is great for type 2 diabetics who cannot have, who are not producing enough insulin because of their diet. Of course, this will not work for a type 1 because we can stimulate the pancreas all we want. If it doesn't know how to create insulin, it won't. Our major adverse effects is going to be hypoglycemia. Your number one side effect for an oral anti-diabetic is going to be low blood sugar because we can always lower it too much. A lot of these are going to be no alcohol because of that disulfiram-like reaction that we talked about with the antibiotics. We have our meglitinides. This is our repaglinide. Again, causes the pancreas to release insulin. It can cause hypoglycemia and nausea and vomiting. Again, only for a type 2 diabetic. And monitor your symptoms for hypoglycemia, and we'll talk about what to do with that in a minute. Biguanides. This one is huge. This is your metformin. So this is going to slow your liver down. Instead of working on the pancreas to make insulin, this is going to slow the production of glucose in your liver so that your glucose doesn't go as high. Because of this, there is a lower or a decreased glucose absorption rate in the GI tract. This is going to cause some nausea, vomiting, gastrointestinal effects. Typically, they do subside over time, but sometimes not. drug of choice for type 2. So if you start out as a type 2, this is what they're going to start putting you on. No alcohol with this, can make you very sick. And you can get a B12 and folic acid deficiency. So what do we do for that? We need to monitor for a folic acid deficiency and replace as needed. You may even go ahead and put them on a B12 or folic acid supplement if you know that they're going to be on this. A lot of times this medication comes in extended release, so we're not going to crush it. The big piece of this is that lactic acidosis, okay? So what happens with this is, where this usually comes in handy is lactic acidosis is going to come from kidney failure. This medication is very, very toxic to the kidneys. So is contrast dye that you would use for like an MRI or a CT scan. If you have a client who is on metformin, you need to stop the metformin 24 hours before surgery. So yeah, stop 24 to 48 hours before the procedure, before the contrast is given. We cannot restart the metformin until after 48 hours, and we get a normal a normal kidney function test. So our normal BUN and creatinine and normal output. So we can't start it before the 48 hours, but if it's been 50 hours, but their BUN and creatinine are still through the roof, then we are not giving that medication. So we really got to check those kidney functions, especially with contrast dye. Okay. Next we have our thiazolidinones. Jeez. Pioglitazone is going to be one of our prototypes. So it decreases our resistance to insulin, so it helps us utilize our insulin in our body a little more effectively. This medication, of course, it can cause the low blood sugar and all that, but it also comes with fluid retention, high cholesterol, liver toxicity, upper respiratory infections, and headache and muscle pain. So big things, fluid retention. We want to monitor for things like edema and weight gain, because remember, weight gain is going to be our biggest indicator of fluid gained or lost. Monitor our cholesterol levels and monitor for symptoms of liver toxicity. So this one, and your big one. Okay. So now we have our alpha glucosidase inhibitors. This is our Archibos. It does cause GI issues just because of how it's stopping the process throughout our GI system. It can cause iron deficiency anemia, so we may need to do things that help with that, like iron supplements and things like that. And then, of course, we want them to report any signs of iron deficiency anemia like fatigue and pallor. It is that hepatotoxic, so we want to monitor for that. Any kind of dark urine, pain in the stomach, vomiting, fatigue, jaundice, anything like that. And we've already talked about the hypoglycemia. Next we have our gliptins. sitagliptin is going to be this one. It can cause upper respiratory infections and severe headache. It can also cause pancreatitis. So we want to be really mindful. This is another thing that we're going to be mindful of abdominal pain with, because that could be a sign of pancreatitis. We can get Stevens-Johnson syndrome, which is a very, very, very deadly rash. We're going to talk about that more, about other drugs that cause this, so we need to be really mindful of that. And of course, anaphylaxis with angioedema. Biggest thing is if we have GI upset that persists or we have that pain, make sure that we are monitoring and reporting it, because it could be that pancreatitis. Okay, so next we have insulin. I do not expect you to memorize the onset, peak, and duration of insulin. I need you to know what onset, peak, and duration means. So onset is how long it takes to start working. Peak is how long it takes to be doing the most work in the body. And duration is how long it lasts for the whole dose. I need you to know that when an insulin is peaking, they are at high risk for hypoglycemia. And we need to monitor for that and make sure they're given food. Okay? We have our regular insulin. Again, it can be mixed with NPH, which is something that we'll be doing in the lab. Regular insulin is the only one that can be given right in an IV. So the only medication that can be given IV, as far as insulin goes, is regular insulin. None of the others can be given IV. Like I said, we're going to mix insulin in class, I believe, week 6. And then, so I'll show you how to do that. We are going to have our NPH insulin, which should be very cloudy. And if any of the other ones are cloudy, you need to throw it away. And then we have our long-acting. This is going to be our glargine. We are going to want to give this at the same time every day. And long-acting insulin cannot be mixed with anything. It has to be given by itself. As far as storage and key points, storage, when they are unopened, they can be kept in the refrigerator until the bottle's expiration date. That's printed by the manufacturer. When we have an open vial of insulin, it can be stored at room temperature and must be discarded after 30 days. So, of course, one of our side effects of this is going to be low sugar, low blood sugar, so we have to monitor that. And it can also cause low potassium, because what insulin will do is it'll take those potassium cells and take them out of the blood and move them with the glucose. So you can get low potassium. Insulin is also, regular insulin IV is also a treatment for hyperkalemia or high potassium. When we administer medications, we want to rotate the sites within the same area. So this prevents lipohypertrophy, but maintains our absorption. So we want to rotate sites. So by rotating, top of the arm, bottom of the arm, the thigh, rotating within the thighs, or rotating within the stomach. But what you want to do is, if you always give it to yourself in the stomach, rotate different sites on the stomach. Don't give it to yourself in your stomach one day and your thigh the other day, because there's a different absorption rate. Alright, so now we have our non-insulin injectables. These medications are just like they sound like. They are injectable things. They are given subcutaneous. but they are not insulin. So pramlintide is going to decrease gastric emptying and inhibit the secretion of glucagon. So we can have some nausea and irritation at the site, so we definitely want to make sure we rotate our sites. Exenatide is the big one because it can cause, it helps by releasing insulin and decreasing the secretion of glucagon, but it can cause GI effects, which is fine, but we may want to notify the provider because it could be a sign of something bigger like pancreatitis. So exenatide causes pancreatitis. And then lastly, for diabetes, we have our hyperglycemic agent. We have glucagon. This is going to increase our blood glucose. So this is someone whose blood glucose is too low. It can cause GI issues, nausea, and vomiting, and it is typically given IM. Another option that we can do if they have an open IV line is give dextrose 5%, which is pretty much sugar water. And we're going to talk in class about the differences of when you would use one versus the other. All right, so now we're going to move on to our other endocrine disorders, and I believe we start with thyroid. So we need to look at things about our normal thyroid levels. So when we have hyperthyroidism, we think about Tigger. He is orange, which it means it's a warmer color, it's hot. It means they are always hot and sweating and maybe have that diaphoresis. They can have a fever, things like that. Abdominal cramping, Tigger is a lot smaller than Eeyore. He is going to these people are going to have a lot of weight loss, even though they're still eating because their thyroid is metabolizing everything. They're going to have anxiety and tachycardia, which can lead to chest pain and tremors and heart palpitations. So we need to be mindful of those side effects. So for hypothyroidism, we're going to have Eeyore. He is blue. These people are going to be frigid and cold all the time. They're going to have dry skin. They're not going to really be able to eat. They're going to have anorexia, but they're going to have weight gain without even trying. Even though they're not really eating, they're going to have that weight gain, along with their edema. They may have like depression and drowsiness, bradycardia, fatigued, things like that. So when looking at treating these two disorders with meds, we have our levothyroxine. This is the only option to treat hypothyroidism. The good news is there's only one side effect for you to really know, and that is that just like with anything, we can over-medicate, which means we give them too much, and that can cause the signs and symptoms of hyperthyroidism because it's the opposite. Because our goal is to increase the thyroid with this medication, we can always end up increasing it too much. So that we would have to look out for signs and symptoms of hyperthyroidism. Our next type of medication that we're going to talk about is our PTU, propylotheracil, and methimazole. These are our thiamides medications, is like their overall class, and they are used to treat hyperthyroidism. Just like with our levothyroxine, we can always over-medicate. So if we're treating hyperthyroidism, we're trying to bring down the thyroid, we can always bring it down too much and cause low thyroid. So we need to be monitoring for our signs and symptoms of hypothyroidism. Another big thing that this one can cause is the agranulocytosis. Remember, this is our decrease in white blood cells. So we're at risk for infection. So we want to report things like fever, sore throat, fatigue. We want to avoid crowds. We want to wash our hands, things like that. You can remember P for pregnant. PTU is the only one that is safe for pregnant women. And liver injury and hepatitis with PTU. We need to remember to monitor for our abdominal pain, dark urine, clay-colored stools, anorexia, abdominal distension, things like that. So next we have our radiopharmaceuticals, which is our radioactive iodine. This is useful for helping some hyperthyroidism, especially that hyperthyroidism that can be caused by thyroid cancer. So just like you talked about in MedSearch 1 when you talked about chemotherapy and radiation, this is going to have some of the same side effects as radiation, which is going to be that radiation sickness. We have the hematemesis, which is vomiting up blood, epistaxis, which is that bloody nose, nausea, vomiting, and a suppression in the bone marrow. What does a suppression in bone marrow look like? That is a decrease in white blood cells, so your agranulocytosis. That is a decrease in platelets, which means an increased risk for bleeding. So we're at risk for bleeding and infection, so you got to remember both of those. And then you also have to remember that when someone is on this, they still have to have radioactive precautions. So this is going to be that maintaining the 6 feet from others. Do not prepare food for others or share utensils. We're going to limit contact to 30 minutes per day per person and dispose of body waste as instructed. As a nurse caring for this person, we want to make sure that we are wearing our dosimeters and being mindful of that. So next we have our iodine products. So this is non-radioactive iodine. So it's iodine that is not radioactive. So we don't have to worry about radiation sickness or radiation precautions. But so it's going to be used to inhibit thyroid hormone and block the release of hormones into the bloodstream. The reason radioactive iodine and iodine helps is that hyperthyroidism can come from a lack of iodine. So iodine kind of helps with your thyroid function. So our goal is to decrease the amount of thyroid hormone in the body. This is typically used in treatment of thyrotoxicosis, which is deadly. It's very, very high, or thyroid storm, or it will help reduce the size of the thyroid before we have to remove it surgically. Okay. And then our side effects, the big one is iodinism, which means too much iodine. So with this, we can have metallic taste, stomitis, which is that inflammation or almost like wounds on the inside of the mouth, which causes sore teeth and gums, headache, skin rash. We can give sodium thiosulfate to reverse the iodine. A big teaching point is we're already giving them a bunch of iodine and we're at risk for iodinism being too much iodine. We want to limit or eliminate the foods that contain iodine, and especially salt. We have iodinized salt is what most of our salt, if you go next door to Food Lion and look, most of it is going to say iodinized. You are going to have to get the one that is not iodinized if you have this. All right, so now we have growth hormones. This is our somatryptin. So this is going to be used to help somebody who have growth hormone deficiencies, such as Turner syndrome. It can also help if someone who has wasting syndrome with HIV and AIDS. And it can also help to increase lean muscle mass in adults. It's going to be given IM or sub-Q. And we want to make sure we're, of course, if we're trying to make our patients grow, especially maybe a child with stunted growth, we want to make sure that we're monitoring their height and weight to make sure that they're growing the way that we want them to. It can cause high blood sugar and high calcium, which can cause renal calculi, which can cause renal issues. So, of course, we want to be very careful with our patients who have diabetes. It can, we want to make sure that our patients getting this, like I said, they're just being monitored, because typically this is going to be in children to help them grow, or in adults who have wasting syndrome. So we want to make sure we're monitoring their growth closely to make sure what we're doing is working. And then we have our antidiuretic hormones. So when we talk about the cardiac system, we're going to talk about our diuretics. Diuretics make you pee. So antidiuretics stop you from peeing. This is going to be used to treat diabetes insipidus and nocturnal enuresis, meaning bedwetting, and diabetes insipidus, meaning that you just pee and pee and pee and pee and pee, and there is no stopping it. So then we have our side effects. If we are not peeing because of this medication, we have stopped our peeing, we're going to fill up with water. So we do have a risk for water intoxication. That means there's too much water on the body. We want to make sure that we report signs and symptoms of this, which is going to be pounding headaches, fatigue, fluid retention, weight gain, and edema. We do want to limit fluids during this time to prevent the water intoxication. And it can cause myocardial ischemia, which is going to be looking at dying heart tissue. So we need to make sure that we report any kind of chest pain or chest pressure. Because what it's doing is it's constricting, it's a vasoconstrictant, so it's tightening up on our arteries and our vascular system, so it can stop the blood flow from going to the heart. So we have to be really mindful about that, and we would not want to give this to anybody who has a cardiac condition. Then lastly, we have our adrenal hormone. This is looking at, again, glucocorticoids. So pretty much nothing changes from when we talked about them last week in the pain and inflammation chapter. But when we're using it in the endocrine system, it's usually used to treat adrenal insufficiency for someone with Addison's disease. Typically, we're not going to have a lot of side effects with this when we're using it for adrenal issues, because the dosing is going to be so low. But what can happen, especially if our dose is too high, or if we're using it for pain instead of adrenal hormone, we get that high blood sugar, osteoporosis, adrenal suppression, peptic ulcers and bleeding, which leads to GI discomfort. We have infection, high risk of infection. So we want to monitor the CBC and glucose at all times. And we also have the risk of putting them into Cushing's, which is the opposite of Addison's disease. And that is it for endocrine.